So I'm very happy to be here, and I want to thank Omid Hamida for this and the Angeles Clinic for inviting us. I think this is a fantastic symposium, and I hope that this is useful for you as well to learn about this and some of the newer ways that we are treating melanoma. Now, what I want to talk about is oncolytic immunotherapy and how this is changing the treatment for melanoma. Now, we talked about disclosures, and I agree with Dr. Hamid is that the more disclosures you have, the more balanced the talk will hopefully be. What I want to talk about is really talk about the background. What is oncolytic immunotherapy and how can we use this? And then especially how we've developed this in melanoma. And the melanoma has really been in the forefront of developing all of this technology. So St. Peregrine Laziosi, so he had a cancer on his leg. The surgeon was going to take the leg off. He came to see him. The tumor was getting smaller. And eventually the tumor went away. And so back in the 1700s, he was actually canonized then to become the patron saint of all cancer patients. So we may then ask, well, you know, did the infection actually lead to the cancer going away? Were there something in him having an infection that led to this cancer going away? Now, William Cooley was a surgeon who in the 1800s discovered that if you took some extracts from bacteria and gave this to patients, especially with patients with sarcomas, soft tissue sarcomas, the cancer would actually go away. Not in all patients, but in many patients. Now again, this was extremely controversial. You're giving bacteria or extracts of bacteria back to patients to try to treat their cancer. And what happened is that from about the late 1800s up to about 1940, this was used a lot, something that we may not be aware of. But it wasn't until much later that they actually went back and analyzed the data that William Cooley had collected in doing this and found out that in these cancer patients, the remission rate was 64% and the 5-year survival was 44%. Today in sarcoma, if anyone had this would be an absolute breakthrough. But it's something that we haven't really used, and there's been a lot of criticism of this. But I think it shows us that there's something potentially about these infectious agents that may help cancer patients. Now, in the early 1900s, in women with cervical cancer, they found that if they gave them a rabies vaccine, they actually had a short remission of their cancer. And then in the 1940s and 1950s, they had other vaccines and viral infections, specifically in patients with leukemias and lymphomas. Most of you, if you're European, you would all have been BCG vaccinated. So that's what we used against tuberculosis. So sir, are you European? Very indirectly, okay. Because I'm European, I was BCG vaccinated. So again, so when we had, in my hospital, when we have to do a TB test, they say, you've had tuberculosis. I said, no, I had vaccination. So the BCG, actually in Finland, where I'm from originally, showed that it may be protective in patients who've had BCG vaccination against leukemias if the BCG was given very early on in life. So the rates of leukemia in Finland compared to many other countries is actually quite a bit lower. So the whole question, we don't know if that's a direct effect or not, but again, indication that maybe some of these vaccinations may help. Now, what about melanoma then and having vaccinations? So they looked at, again, in Scandinavia, having BCG and Vaccinia vaccinations. If you were given this, there was actually some indication that patients may have a lower rate of melanoma, having received these vaccinations at an early point in life. Again, indirect indications. We're not saying it's a cause and effect, but again, maybe there's something about these vaccines, they may activate the immune system to help fight these cancers. So why is that important? Well, it's important because with this data and also other data, we've now come to realize that maybe we can use some of these vaccines to try to fight melanoma. And melanoma, when it comes to developing these types of oncolytic immunotherapies, and I'll get back to that shortly, has really been in the forefront. And the reason being is that many of these therapies, we have to inject them directly into the tumor. But melanoma lends itself to that because we know in patients that have melanoma, melanoma can come back. And when it comes back, it often comes back on the skin or in the lymph nodes. And these are areas that we can easily get to. Whereas if you have lung cancer, if the lung cancer comes back, well, it comes back inside the lung. It's a lot tougher to inject something into the lung. Same thing with liver cancer. So we have really started to study this in melanoma to try to figure out how to use these vaccines. Now let's talk about BCG. So Dr. Ferris, who's going to speak to us after the break here, at his institution, Donald Morton, who's really in the forefront of leading a lot of this research, showed in the 1970s that if he took BCG, remember that's the vaccination that we gave for tuberculosis, if he took that and injected that directly into the tumor, in a lot of tumors, the tumor would go away. But he also didn't only see responses in the tumor that he injected, he also saw responses in uninjected tumors, indicating then that maybe this virus was able to activate the immune system to fight the melanoma at those non-injected sites. So again, early indication that we can use this. The question is then, does this work? And the answer is, it can work very well. This is one of my patients. This is a 93-year-old gentleman who came in who had a melanoma on his arm, and the melanoma came back and had a lot of this in-transit disease on the arm. He was in pretty frail health, so he was not a candidate for many of the therapies that we just talked about, these immunotherapies. And so what we did is we injected BCG into his arm. And after a few weeks, the tumor went away. And he's actually still alive and doing very well, indicating then that we may be able to use these vaccine to activate the immune system to fight the melanoma. Now, there are issues though. If we take these crude vaccines, they may not be very specific. It's a little bit like trying to go to try to swat a fly and take a big cannon to try to do that. You know, it's very difficult to steer the cannon. It's very difficult to put it on the right spot. And when you shoot it, well, you're going to have a lot of collateral damage too. So I think that a lot of these early treatments with vaccines and other treatments have been very crude. But a lot of that changed actually in the 1970s, because then we developed recombinant DNA technology. Now what this means is that we were then able to look at the DNA of the vaccine, or so of the virus, and we were able to change that DNA. So take certain part of their genetic material out, put other things in, to try to make these viruses more specific at fighting the tumor. And one of these viruses that have been developed is called T-VEC. Now the actual name is telimogene laherparepvec. It's a bit of a mouthful, so we call this T-VEC. Now this is a herpes virus. So the type of herpes, if you develop mouth sores, so 80% of the populations have been exposed to herpes. You can develop mouth sores from that. Now this T-VEC is a herpes virus, but they've changed it so you don't get herpes from it. And they've taken parts of the DNA out, then they've added other parts to try to activate the immune system. So when we inject this into tumors, we really try to augment the effect that this has on the immune activation. Now, we have the targeted therapies where we have these small molecules that we can use, these pills that Dr. Carvajal talked about, that really goes in and finds these switches in the tumor that we can affect. And then we have the immunotherapy, where we really try to activate the whole immune system, not a specific switch, but the whole immune system to fight this. And I think that they both have their advantages and disadvantages. But this is really how we're looking at this right now when we talk about immunotherapy. Now, Dr. Hamid showed this. So the way that I describe this to my patients about immunotherapy is like driving your car. What we want to do is we want to activate your immune system to rev it up for it to go faster. And there are two ways we can do that. It's like driving your car. If you want to make it go faster, you press on the gas. Or if you forgot the pesky handbrake on, you take the handbrake off. And that then leads to you being able to activate the immune system. Pretty much all of the treatments that we have right now do these things. They sort of either press on the gas or take the handbrake off. A lot of the treatments that Dr. Hamid talked about, the Ipililumab and the PD-1 inhibitors, these are the ones that take the brakes off the immune system. What I'm going to talk to you about right now is these things that pushes on the gas and really activates your immune system. So what is then oncolytic immunotherapy? Well, as the name says, it's oncolytic, which means that it lyses, it makes things burst open and kills these cells. Now, how do we do that? Well, we can do it with many different techniques. We can use viruses, we can also use different chemicals to do it, and we can even have a mechanical ablation. So you take something and you just basically rub it in and try to kill these cells. But also you have an immunotherapy. And that's really, I think, the most important aspect of this. not only are we killing the cells directly where we're treating it, we're trying to then activate the immune system so that it kills other cells at distant sites that we have not treated directly. These are some of the agents that have been developed for this. As I said, you have viruses, we have plasmids, and that's just sort of small pieces of DNA. We also have antibodies, radiosensitizers. Melanoma really has been the key disease to develop all of these techniques. Now, so this is sort of a sum of these agents that have been developed. Now, the way this works, the way we think about this, you have preclinical stuff. This is usually done in animals. So all of these treatments have been done in animals and in the petri dishes and cell cultures before we then take them to humans. When we take them to humans, we have different phases of this. Phase 1 is usually very early. We're looking at, is this safe? We may look at a bit at the signal. Are we seeing that this actually is working for the cancer we're trying to treat it with? But phase 1 is really looking at safety. Phase 2 then saying, okay, we know that this was safe, but can we get this to work in the cancer that we're trying to use it for? And that's what we had the phase 2. And phase 3 is then saying, we have a lot of information, but now we need to compare it to something else and see if it works equally well or better than a comparator that we're trying to compare it to. Most of these treatments have been in phase 2. Basically, we have smaller groups of patients, but there are a few that have been in phase 3, and I'll talk to you a bit more about this. So let's talk about how this works. And so my patients, when they come to clinic, and same as Dr. Hamid's patients also, because we participate in a number of these clinical trials together. So the way I explain this to my patients, and they usually come and they have then a lesion that is either on the skin, just underneath the skin, or in a lymph node. And what we do is we inject these therapies directly into those lesions. And the way I describe this to my patients is that when the virus or the different treatment gets into the tumor, they preferentially goes into the tumor cell because we've modified them, we've changed them so they really hone in on the tumor cell and they don't go into the normal cells. Once they're inside the tumor cells, especially the viruses, they produce new virus particles, so they replicate. And that leads then to the cell being burst open. And melanoma cells are really good at evading the immune system. So you have all of these cancer proteins sitting inside the melanoma cell that is hidden from the immune system. But what happens then when these cells burst open, all of a sudden you have all of these cancer proteins that then come out. And the immune system says, this should not be here. This does not look normal. We need to fight this. So the immune cells then come in and start fighting those melanoma cells right there where we've injected this. But also what the immune system does, it actually creates a memory. So it tells these immune cells that if you ever see these proteins elsewhere, anywhere in the body, you need to go and fight them as well. So we want to have an effect not only in the area where we directly inject, but we want to activate the immune system to fight this at distant sites that we have not injected. Now let me show you a video. This is actually one of my patients. For those of you who find this uncomfortable, you may want to look down. But this is actually one of my patients that has melanoma that has come back in the neck. And this patient is on one of these oncolytic immunotherapy virus trials that we have. And we're injecting this directly into this lesion. And I must say, overall, patients tolerate this really well. Sometimes we put a bit of numbing cream on top of the skin, but overall, this is really tolerated very well by patients. So this is actually Jennifer, who is my research nurse, and she injects this directly into the tumor. Now, these tumors can be really hard. So Jennifer used to be actually an international ballet dancer. She was world class. So I can tell you, you don't want to mess with Jennifer, and she was strong. So you can see, but see, even with Jennifer, she has to push this quite hard in sometimes to really get the virus in there. But then, and also what she does, she puts this at the surface of the tumor, not in the middle, because all of those immune cells that we want to activate and fight the tumor tend to be at the surface of the tumor. So Jennifer is pushing this in. Now the patient, he's not a 30-year-old man who are the worst kind because they're really squeamish. He's a gentleman in his 80s, and he just sits there very stoically like nothing is happening. So he tolerates this very well. And then we just put a small bandage on, and the patient goes home. So very well tolerated by patients. So when we do this, we have several goals in mind. There are things that we want to accomplish. We want these treatments to do. First of all, where we inject it, we want to have a good local control. We want this tumor to go away. But we also want to activate the immune system to fight the melanoma at distant sites. And the way I think about this, we have two types of distant sites. We have the ones that are in the vicinity of where we've injected this. So for instance, if you have the melanoma on the leg, and you have a lot of these in transit melanomas on the leg, it would be some of the other in transits on the leg that we have not injected. It may also be a lymph node in the groin that we have not injected. We want the melanoma in those areas to go away as well. But we also want to have this if you have lung metastases or liver metastases. We want to activate the immune system to go and fight those in those areas. The other thing that we want to accomplish with this, patients with earlier melanomas, and patients who do not yet have melanoma that has gone to the liver or the lung, we want to prevent them from ever getting melanoma in those areas. The best sort of way to treat melanoma is prevent them from ever getting disease in those sites. So these are a goal that we'd like to achieve with these oncolytic immunotherapies. Of course, we want then the responses to be long-lasting. So these are durable responses. Like Dr. Hamid talked to you about, this Ipililumab. You get these patients who live for years and the melanoma never comes back. We want to achieve the same thing. And we want to have this with limited toxicity. We want patients to tolerate this well without toxicity. Let me go through some of these treatments that we are doing this with and just show that there are different ways to, as you should say, different ways to skin a cat. So we have these mechanical things. This is called electroporation. What this is, these are these small, tiny catheters or electrodes that we put in directly into the tumor. We apply a current. And what that results in, it results that all of these cells, these melanoma cells, the envelope around them, or the cell membrane, gets more holes in it. It's like punching holes. And when you punch those holes, we then inject either a standard chemotherapy or a plasmid. Plasmid is a piece of DNA that we inject directly that goes into the tumor then. So, and this has been done a lot in Europe, but also some in the US. So this is a really good friend of mine who's Alessandro Testore, who's in Milano. And he's been really the champion of this in Europe, using this with standard chemotherapy. And what they found is that you can get responses in the areas that they treat directly with this, but also in areas that they don't treat. Now, Dr. Hamid showed this actually, is that sometimes when we treat these, especially these lesions are really raised, but after a few treatments they become very, very flat. But they're still pigmented, and that pigmentation may not go away. It may be there long term. But when you take a sample of that and look at it under the microscope, it's just pigmentation. There's no melanoma cells left. And this is something we see quite often with these treatments. Now, let's talk about another way of doing this. This is PV10. Now, this is actually a chemical. This is a fluorescent compound. And we take this and we inject it directly into the tumor as well. Over half of the lesions, things go away, but also things that we don't inject, the lesions go away as well. This is Coxsackievirus A21. Now, this is a cold virus, and virtually all of you have had this virus at some point in your life. You've been exposed to this. Now, this virus has been chosen because it's very good at fighting the melanoma cells. So what we do with this, we inject this then directly into the tumor as well. And we found that with this, we also get good responses. We see these waterfall plots. We see a lot of patients responding to this. Let me show you some pictures of what we see in the clinic. So this is a patient, again, that's a lot of raised melanoma. We inject this, and the melanoma flattens out. Then we do a biopsy, and there's no melanoma left. This is a patient here that has a lot of these in-transit lesions that we inject only a few, but after multiple injections, we see responses, not only the ones that we treat, but also in the ones that we don't treat. This is a patient that has melanoma on the arm that we inject, but also has metastatic melanoma to the chest wall. And we see responses in those uninjected chest wall lesions as well. One of my patients had a huge melanoma that came back in the back of the ear, but also had lung metastases, and we saw responses not only in the injected lesion, but in the lung metastases as well. One thing about these treatments, they're extremely well tolerated. Patients have very few side effects. The most common thing is a bit of shakes and chills, just like getting a vaccination, but otherwise they're very well tolerated. So you don't lose your hair, you don't have the standard effects of that many chemotherapies would do. Now, who is this? Who? Anyone? George Washington. Who is this? Bob Marley. Okay. What about this? John McCain. This? Troy Aikman. Yeah. What about this? Sam Donaldson. George Herbert Bush. Now, for the money point here. Well, not actually. Ike Eisenhower. Now for the money point. Not the boss, but the person next to the boss. Who is this? Ah, that's more, any E Street Band fans. This is Danny Fedici. So all of these have had melanoma, and some of them actually have succumbed to their melanoma. But I think that had they been treated now, at this day and age, many of them would have been very much better off. Let me talk to you about the T-VEC and how that works. So this was a large study that we did when we looked at T-VEC and see how we could treat patients with this. We compared it to GM-CSF. Now, GM-CSF is something that activates the immune system. We found that the T-VEC worked much better than the GM-CSF. Specifically, we found that patients who were treated with the T-VEC had a very long-lasting response if they responded to it. What we found was if we use these goals that we want to use with this, we found that, again, one of my patients here, when we start treating them with T-VEC in these lesions, the lesions go away. And in the large study that we did, we found that over 2/3 of patients, the lesions responded in the ones that we injected in. But we also wanted to see responses in the uninjected lesions. And this is a patient that has a lot of melanoma in the leg, has had a lot of surgery. But we see responses not only in the lesions that we inject, but also in the uninjected lesions. And here we found that about 1/3 of patients had responses in these uninjected lesions. What about responses at distant sites? This is a patient that has melanoma in the neck, melanoma in the flank, and a lot of melanoma in the retroperitoneum. We injected the neck and the flank, but saw responses in the retroperitoneum as well. And we saw that in about 15% of patients. So can we use T-VEC then to try to prevent patients from adding metastases to the lungs and the liver? And we've looked at that, and what we found was that, yes, it appears that we can do that. It appears that giving someone treatment with T-VEC prevents them or decreases the risk of developing disease in those distant sites. And if they develop it, it may take longer for them to have that. So again, very encouraging. Now, all of these patients that I just showed you had unresectable disease. These are melanoma that we could not take out with surgery. But there are many patients that come in and have melanoma that has come back in just one lymph node. Right now, the main treatment for those patients is surgery. When we do surgery for them, we know that there's a high risk of the melanoma coming back. And the adjuvant therapies that we have, kind of the immunotherapies, the interferon, even the Ipililumab that Dr. Hamid talked about, that we give after, probably does not work as well as we'd like to do. Most patients have tolerated these treatments extremely well. Now, it's important to remember, though, it doesn't work for everyone. And it probably doesn't work as well as we'd like it to work. So really, I think many of these, we need to think about doing this in combination. We need to combine things to make it work even better, same as Dr. Hamid talked about. So how do we do that combination? Well, remember, T-VEC pushes on the gas pedal when you drive the car. And Ipililumab, which is the CTLA-4 blockade, takes the brake off. So maybe to really rev up the car, we need to push on the gas and take the brake off. So that's what we're doing in a study. And Dr. Hamid presented this a little bit. Now, when you do that, though, same as driving your car, you want to make sure your car doesn't go too fast. You want to make sure that your immune system does not go in absolute overdrive. You still want to be able to control this. So when we did this study, and we asked the question, if we have the Ipililumab and we put the T-VEC together to it, do we have more side effects for patients? And the answer was no. So adding T-VEC to that did not seem to increase the amount of side effect. But the responses that we saw, again, very early, but the initial responses, we saw a better response than we would expect to see with Ipililumab alone or T-VEC alone. So again, encouraging data that we can combine these things to try to activate the immune system. Based on that, there are now a number of treatments being done using these oncolytic immunotherapies in combination. One thing is, we don't fully know how they work, and we need to understand this mechanism of action. And so we know that when we give patients a virus, you develop antibodies against it. The body's trying to fight this virus, saying this should not be here. And so we asked the question then, when we give them this virus then, can we even see a response? Because the body's immune system is there to fight the virus. Can we see a response even if you have these antibodies against the virus? And the answer is yes, we see responses with that. So that indicates to us that it's not just the killing effect of the virus that's important, but it's also activation of the immune system that leads to us seeing these responses. We can go over that a little bit here. So now, one thing with all of these therapies is that we need to understand when to use them and how to use them. You've heard about Ipililumab. You've heard about the PD-1 inhibitors. These are great drugs, but there are many patients that don't respond to them. Or there may be patients that respond initially, but then stop responding. So the question is, can we use these viruses then to try to make them respond again to these therapies? So what we've done here is that we've taken patients that have been on Ipililumab, have been on a PD-1 inhibitor, and they are now, tumor is getting bigger. And then we do a biopsy, part of their sample, and look at it under the microscope, and we ask the question, in that tumor, do we see these immune cells that we need to have there to fight the melanoma? And what we found in that is that no, we did not see, so very few immune cells in there. Then what we did, we said, well, let's give them this oncolytic immunotherapy. Just give 3 injections of this. And let's then do a biopsy again and see if we can get this oncolytic immunotherapy to bring those immune cells back into the tumor to try to fight the tumor. And the answer is that we saw that. So now we're starting to ask the question then, in patients then that are not responding anymore, can we now give them this oncolytic immunotherapy to try to reactivate the immune system and continue with those PD-1 inhibitors? We don't know that, but we're starting a study right now looking at that. So let me finish off. I think that the most important thing in all of this is really you. It's not us. This is about you. Without you, none of this would be possible. So it's really patients and the patient's family that we are in ultimate gratitude to that really makes all of this possible. So let me sort of finish off with a conundrum that we have as clinicians, but that most patients look at very differently than we do. This is one of my patients, a 55-year-old electrician, perfect health otherwise, developed melanoma on just below his lip here, had that resected, and had his sentinel nodes taken out, and they were negative. About a year later, he came back then and had evidence of disease in both sides of the neck. And otherwise doing well. So he went on one of these oncolytic immunotherapies that we injected directly into the lesion in the neck. But after 5 months, the lesions got bigger. We know it takes time for these immune therapies to work. It may take several months, but this was growing quite a bit. So we said, obviously, this is not working. So we need to switch to something else. So we then, and this was around the time where Ipililumab became available, we switched him to Ipililumab. And there was also some indication that if we had the Ipililumab with radiation, we may be able to activate the immune system even more. So we gave that to him. But with that, he still had melanoma in those lymph nodes, and it was still sitting there, maybe about the same size, but growing potentially a little bit. So I think that these oncolytic immunotherapies are extremely well tolerated by patients. They have low toxicity. We see responses in both the areas that we inject, but also in other uninjected areas. I think that they can enhance the effect of many other immunotherapies. And in combination, I think they will get better responses than we see with either agent alone. And I think they represent a very important new strategy in the treatment of cancer for patients, not only with melanoma, but also many other cancers. So with that, I want to thank you. We're taking a break.